Hello everyone, this is Nibedita. Welcome to my YouTube channel and G's Corner for Nurses. Hope all of you are doing well. For today's session, we have a special guest with us, Miss Komol Kundu. Komol was my student and recently she completed her master's in nursing and her specialization is obstetrics and gynecological nursing. And presently she is working as tutor in International Institute of Nursing and Research, Kolani under the West Bengal University of Health Sciences. Today, our speaker will sharing insights on fetal cardiotocography. So join us in this eye-opening video where we dive into the world of cardiotocography, a vital tool in monitoring fetal health during pregnancy. Let's start today's session. Now the session is yours, Komol. Please start.
First of all, my heartfelt gratitude to Nivedita ma'am for giving me this wonderful opportunity on her YouTube platform. My name is Komol Kundu and I have done my specialization in obstetrical and gynecological nursing, and today I would conduct this session on a very interesting topic, fetal cardiotocography. There are various methods or diagnostic tools to monitor the fetal well-being, one of which is cardiotocography. In short, we know it as CTG. It is a widely used non-invasive technique used to record fetal condition both in the antenatal as well as in the intranatal period during the labor process. It not only gives an idea about the fetal condition but also gives information about the maternal uterine contraction. So, as midwives, it is our prime responsibility to have a good knowledge and understanding about the CTG so we can contribute in the early detection and timely intervention for any kind of fetal abnormality, thereby help in reducing the perinatal mortality and the morbidity rate. So in this session, we would be looking into the definition of cardiotocography, what are its purposes, what are the methods of performing a CTG, indications, parameters that we observe in a CTG, how to interpret a CTG graph, and lastly, if abnormal CTG is there, then how to manage the situation. So starting with the definition, the very term cardiotocography itself, it suggests that it is made up of two words or two components. One is cardio and the other one is toco. The cardio term, we know it is related to heart. So the cardio deals with the heart rate of the fetus, and toco stands for the uterine contraction of the mother. So we can basically assess two things by a CTG. First one is the FHR, that is the fetal heart rate, and the other one is the maternal uterine contraction. So based on this, CTG can be defined as a technique used to monitor the fetal heart rate and the uterine contractions during the pregnancy, that is in the antenatal period, and during the labor, that is in the intranatal period. And the graph that we obtain is known as cardiotocograph. The procedure is known as cardiotocography and the graph is known as cardiotocograph. So this here is a sample of normal cardiotocograph, and as you can see here, there are two graphs plotted here. This is one graph and this is another graph. The graph that is in the above part, it represents the fetal heart rate. That is, the fetal heart rate at various point of time is plotted in this graph, and this is for the uterine contraction. The peaks you can see here, this represents the uterine contraction of the mother. Moving on to the purposes of performing a CTG. So the first purpose is assessment of fetal well-being. CTG basically helps to identify if the baby or the fetus is undergoing any kind of distress or not, if the fetus is hypoxic or not. So by monitoring or studying a CTG graph, we can understand the overall condition of the fetus. Next purpose is detection of fetal distress. The presence of any kind of deceleration in the CTG graph is a sign of fetal hypoxia or fetal distress. Now what is deceleration? That we will study in the further slides. Okay. Next is monitoring of uterine contraction. So as in the definition itself, I have mentioned that cardiotocography consists of two components. Cardio stands for the fetal heart rate, and the toco is related to the maternal uterine contraction. So by studying the CTG graph, we can understand the pattern or the frequency of the maternal uterine contraction as well. For example, at what frequency the uterine contractions are coming can be studied by the help of a CTG graph. Next is prevention of any complications. So if we can identify any complications such as fetal distress or uterine hyperstimulation, then we can take timely action, timely intervention, thereby reducing the chance of complication. And lastly, guiding clinical decisions. For example, if we are seeing that the uterine contractions are coming too fast, that is, there is uterine hyperstimulation and the mother is already receiving oxytocin, then what we can do, we can decide to stop the oxytocin for the time being. Why? Because oxytocin will further increase the rate or frequency of the uterine contraction. So clinical decisions can be taken based on the CTG graph. Moving to the methods or the ways in which a CTG can be performed. So basically there are two methods. One is the external CTG and the other one is the internal CTG. As you can see in this picture, in the external CTG there are two sensors or two transducers or two probes. One is the contraction monitor sensor and the other is the FHR sensor. So this contraction monitor sensor measures or records the uterine contraction and it is placed over the fundus. Why over the fundus? Because the uterine contraction, we all know, starts from the fundus and move towards the lower pole of the uterus. So for the accurate monitoring of the uterine contraction, this transducer is placed over the fundus. Next, where the FHR sensor needs to be attached, so we have to first auscultate where we are getting the fetal heart sound, and then on that exact position on the over the abdomen we have to attach the second transducer to record the fetal heart rate. And in the internal CTG, as you can see here, here an electrode is attached directly to the fetal scalp through an intrauterine catheter. But this method is not widely used as membranes needs to be first of all ruptured, then only we can reach the fetal scalp, and also there are high risk of infection since it is an invasive, it becomes an invasive procedure. So out of these two, widely we see the use of external CTG. Next, in the indications can be categorized under two headings. One is the antenatal indication and the other one is the intranatal indication. One by one, we would see what are the conditions that come under these two categories. In the antenatal indication, first comes the high-risk pregnancies. So any high-risk conditions such as preeclampsia, RH incompatibility or gestational diabetes mellitus, any condition that can contribute towards fetal distress or can lead to a fetal death. So we can monitor CTG in all those cases. Next is fetal growth restriction, then decreased fetal movement. So, if the mother comes with the chief complaint of decreased perceived fetal movement, that is, if she is saying that she is unable to feel any fetal movement, or the number of fetal movement she is feeling right now is lesser as compared to before, then we can perform a CTG to assess the condition of the fetus. Next, in case of post-dated pregnancy, multiple pregnancy, so if there is, suppose for example, twin pregnancy, then in that situation we have to attach three transducer to the mother's abdomen. One will assess the uterine contraction and the other two transducer will assess the fetal heart rate for both the babies separately. Next, in previous stillbirth cases, so if there is a history of previous stillbirth, then there are also chances that in this pregnancy also there can be early fetal demise or fetal death can be there. So it is mandatory to monitor the fetus periodically. And lastly, in case of oligohydramnios or polyhydramnios. So for example, in oligohydramnios, there are high chances of fetal distress. So these are the antenatal indication. In the intranatal period or during the labor, the indication of monitoring a CTG is after induction of labor or augmentation of labor, as there can be decrease in the fetal heart rate due to the increased contraction after the induction or augmentation of labor. Then in case of meconium stained liquor, presence of thick stained meconium in the amniotic fluid can indicate fetal distress. Next, in case of abnormal fetal heart rate on intermittent auscultation. So by auscultating, if we are getting abnormal FHR or decreased FHR, then for reconfirmation we can do a CTG. In case of chorioamnionitis, vaginal bleeding in the late pregnancy, use of epidural anesthesia as a side effect, the fetal heart rate can decrease. So these are the various indications in the antenatal and the intranatal period where we might need to perform a CTG. First, we will start by learning how to assess the uterine contraction in a CTG graph. Earlier, when I have shown you the CTG graph, I have already mentioned the above graph is for the fetal heart rate and the lower graph is for the uterine contraction. So, to measure the number of uterine contraction, we need to record or see how many uterine contractions are appearing in a period of 10 minutes continuously. Now in the graph street, some boxes were there. Each big box is equivalent to 1 minute. So for 10 minutes, we need to look into 10 big boxes or 10 big squares. Then we have to identify each individual uterine contraction that can be seen as peaks or highs in the graph line. Now let's try to calculate the number of uterine contraction in this graph. So these peaks or these highs are the uterine contractions, okay. And what I have told that we need to monitor the number of uterine contraction for 10 minutes, that is for 10 boxes. Each one big box shows 1 minute of time. It is equal to 1 minute of time. So let's try to count the number of contractions in this graph. Let's start it from here. Let's see till where we are getting 10 boxes. It's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So for counting the number of contractions, we have to see how many contractions are appearing between this line and this line. So how many contractions are there? This is one contraction and this is the second contraction. So in this graph, we are getting two contraction in a time period of 10 minutes. Next, we will see how to interpret the graph related to the FHR. So for interpreting the FHR or the fetal heart rate, we need to know about four parameters of the CTG graph. First is the baseline FHR, then baseline variability, next is the acceleration, and lastly is the deceleration. First is the baseline FHR. Baseline FHR, simply we can understand it as the average fetal heart rate over a period of 10 minutes. The baseline FHR is the mean FHR rounded to increments of 5 beats per minute during a 10-minute window, excluding the acceleration and deceleration and periods of marked FHR variability greater than 25 beats per minute. So we have to take out the average of the fetal heart rate for a period of 10 minutes, but in this 10 minutes we need to exclude the acceleration and the deceleration or the variability that is greater than 25 beats per minute. Acceleration, deceleration and variability we will understand in the further slides. Okay. And the normal baseline FHR is 110 to 160 beats per minute. So if we are getting an average that is between 110 and 160, it is normal. But if the fetal heart rate is below 110, it is considered as fetal bradycardia, and if the fetal heart rate is above 160, it is considered as fetal tachycardia. Let's try to calculate the FHR for this graph. So for calculating the FHR, first we need to see from where to where we get 10 boxes that would suggest a period of 10 minutes. So let's start from here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So from this line to this line, we need to take out the average fetal heart rate excluding the acceleration. So between this line and this line, there are two acceleration, one this and the second one is this. After excluding these two acceleration, the rest of the FHR, if we see, majority of them lies at the level of 120. So we can say that the baseline FHR for this graph is 120 beats per minute. And as I have already mentioned that the normal baseline FHR ranges between 110 to 160 beats per minute. So the FHR here can be considered as normal. The next parameter is baseline variability. Variability is nothing but the continuous upward and downward movement or fluctuation of the fetal heart rate in comparison to the baseline FHR, like we have seen in the previous graph. So baseline variability can be defined as fluctuation in the baseline FHR that are irregular in amplitude and frequency. It is the oscillation of baseline FHR excluding the acceleration and the deceleration. Let's try to understand the variability through this graph. So excluding the acceleration and the deceleration, the rest of the upward and the downward movement or fluctuation of the fetal heart rate is considered as a variability. So here this is an acceleration, this is an acceleration, here this is another acceleration. Apart from that, whatever the upward and downward fluctuation we are seeing here, that all are the variability. Okay, and variability we always interpret in range. For example, for this graph, the variability ranges between 10 to 25 beats per minute. That is, minimum it has gone down by 10 beats per minute from the baseline FHR, and maximum it had gone above 25 beats per minute from the baseline FHR. So the variability here is 10 to 25 beats per minute. Based on the number or the range of variability, it can be categorized as absent, minimal, moderate, and marked variability. Absent, when the variability is undetectable, that is, there is none or very minimum fluctuation in the FHR value compared to the baseline FHR. Minimal when the fluctuation, that is the upward and downward displacement of the FHR in comparison to the baseline FHR is greater than undetectable but less than equal to 5 beats per minute. Moderate when the fluctuation ranges between 6 to 25 beats per minute, and marked when the fluctuation is more than 25 beats per minute. Here, out of all these four categories, the moderate one is considered to be normal. So, if the variability ranges between 5 to 25, it is considered to be normal. Less than 5 is abnormal, and greater than 25 is also considered to be abnormal. Now this here is a sample of reduced variability. Reduced variability is the one where the fluctuation in the FHR is less than 5 beats per minute above or below the baseline FHR. As you can see here, the baseline FHR is approximately 150 beats per minute, and the fluctuation that we can see both in the upward and the downward direction is obviously less than 5 beats per minute. So this is a sample of reduced variability. Now, as I have already told, if the CTG graph is having a variability in a range of 5 to 25 beats per minute, it is a normal scenario. But such cases of reduced variability is considered to be abnormal and should be observed critically. Now, this reduced variability can be observed in multiple scenarios, such as fetal sleeping, which is considered to be the most common cause of reduced variability. But if the variability is caused due to fetal sleeping, this should not last beyond 40 minutes. Next cause can be fetal acidosis caused due to fetal distress or fetal hypoxia, and it is more likely to occur in association with late deceleration. Other causes can be like fetal tachycardia if the mother is being administered drugs like opioids, benzodiazepines, methyl dopa, and magnesium sulfate in case of fetal prematurity, as well as in case if the fetus is having any kind of congenital heart abnormalities. The third parameter is acceleration. Acceleration simply means increase in the fetal heart rate. Now, to what extent should the fetal heart rate increase so that we can name it as an acceleration? For the term babies, that is the babies that have crossed the gestational age of more than 37 weeks, if there is an increase in the fetal heart rate by more than 15 beats per minute, and if it lasts for more than 15 seconds, then only we can consider it as an acceleration for the term babies. While for the preterm babies, if there is an increase in the fetal heart rate for more than 10 beats per minute, and if it is lasting for more than 10 seconds, then only we can consider it as an acceleration. Otherwise, it would go into variability and won't be considered as an acceleration. Let's try to understand the concept of acceleration with an example. So in this CTG, the baseline FHR is approximately 120 beats per minute. As you can see, that majority of the time the FHR value ranges more or less near to 120 beats per minute. If we consider these peak, there is an increase of FHR here, and the FHR at this point is more than 140 beats per minute. So it has fulfilled one criteria. The difference between the baseline FHR and the FHR at this point is more than 15 beats per minute. But if we look at the second criteria, then it is not fulfilling the second criteria, that is the duration of this increase in FHR is not more than 15 seconds. Hence, this increase in FHR cannot be considered as an acceleration. Compared to another peak in the FHR level, as you can see here, the FHR at this point is approximately 150 beats per minute. That is, there is a difference of 30 beats per minute between the baseline FHR and the FHR at this point. So the first criteria is fulfilled. Also, here the duration, you can see that this increase in FHR has lasted for more than 15 seconds, a full box of 10 seconds and another box more than half. So it has increased for more than 15 seconds. Since both the criteria have been fulfilled, this can be considered as an acceleration. Same thing goes for this fluctuation as well. Here also the baseline FHR being 120 and the FHR at this point is approximately 145 beats per minute. So there is an increase of more than 15 beats per minute compared to the baseline FHR, and the duration is approximately more than 20 seconds or approximately 20 seconds. So this can also be considered as an acceleration. So these two would be acceleration, but this won't be considered as an acceleration. So for any fluctuation or increase in FHR value to be considered as an acceleration, it needs to fulfill both the criteria. First, it has to be increased by more than 15 beats per minute, and secondly, it should last for more than 15 seconds. The presence of acceleration in a cardiotocograph denote an intact neurohormonal and cardiovascular activity of the fetus, and hence the fetus is considered to be healthy. But in case if any acceleration is not present in the cardiotocograph, that doesn't mean that the fetus is unhealthy or the findings are abnormal. If the acceleration lasts for more than 2 minutes but less than 10 minutes, then it is considered to be an prolonged acceleration. And if the acceleration remains for more than 10 minutes, then it is considered to be a baseline change in the FHR value. Coming to the last parameter of CTG, that is deceleration. Deceleration is complete opposite of acceleration. Here there is transient decrease in the fetal heart rate below the baseline value. Conditions are the same, but here there will be decrease in the FHR value instead of increase in FHR value as we have seen in acceleration. For the term babies, the decrease in the FHR value should be more than 15 beats per minute, lasting for more than 15 seconds, while for the preterm babies, the FHR value should be decreased by more than 10 beats per minute, and it should last for more than 10 seconds. Here in this cardiotocograph, this particular area can be considered as a deceleration, because in this graph the baseline is approximately 120 beats per minute. At this point the FHR is approximately 100 beats per minute. So we can say that there has been decrease in the FHR value by more than 15 seconds, and this decrease is lasting for more than 15 seconds. So this can be considered as a deceleration. One more thing we can notice here, that the decrease in the FHR value is very closely associated with occurrence of the uterine contraction. That is, whenever there is a uterine contraction, we can see that there is a fall in the FHR value. Based on when the decrease in FHR value or deceleration is occurring in comparison to the occurrence of the uterine contraction, deceleration is of three types. First one is the early deceleration, next is the late deceleration, and lastly is the variable deceleration, which we will discuss one by one. In the early deceleration, the graph is usually uniform, repetitive, and there is periodic slowing in the fetal heart rate. As you can see here, this is an example of early deceleration. We can see that whenever there is a uterine contraction, there is simultaneous decrease in the FHR value. Here also, when there is uterine contraction, simultaneously the FHR value is coming down. In early deceleration, the onset nadir Recovery of deceleration coincides with the beginning, peak, and end of the uterine contraction. So onset means the starting point, nadir means the peak point, and recovery means the end point of the deceleration. So whenever there is the starting of the deceleration, there it coincides with the starting point of the uterine contraction. When the uterine contraction is at its peak, the fetal deceleration is also at its peak, and when the uterine contraction is ending, the fetal deceleration is also ending simultaneously. So they are in complete synchronous with each other. This early deceleration mainly happens because of the head compression of the fetus. Whenever there is uterine contraction, the fetus is pushed down and the head gets compressed to the perineum, resulting in the occurrence of early deceleration. So, in early deceleration, whenever the uterine contraction is at its peak, the fetal deceleration is also at its peak, and the starting point and the ending point of the uterine contraction coincides with the starting point and the ending point of the fetal deceleration, and this will happen in case of all the uterine contraction. The uterine contraction will perfectly coincide with the fetal deceleration in case of early deceleration. This is the classical feature of early deceleration, that the uterine contraction and fetal deceleration will happen simultaneously at the same time. Next one is the late deceleration. Here the graph is uniform and U-shaped with a reduced variability of less than 5 beats per minute. This is a sample graph of late deceleration. As the term suggests, the decelerations are coming late as compared to the uterine contraction. As you can see here, the uterine contraction has come first, but the deceleration is coming somewhat later. They are not coming at the same time. Usually the deceleration begins more than 20 seconds after the onset of the uterine contractions, and the onset, nadir and recovery of the deceleration occur approximately 20 seconds after the start, peak and end of the uterine contraction respectively. Now, this late deceleration happens usually because of uteroplacental insufficiency resulting in fetal hypoxia, and the appearance of late deceleration in a cardiotocograph is considered to be alarming and should be critically reviewed. Here in the graph you can see that the onset of uterine contraction is at this point, but the fetal deceleration is starting somewhat here. So there is a delay in the onset of fetal deceleration as compared to the uterine contraction. This is the feature of late deceleration, that is, the deceleration will come later as compared to the onset of the uterine contraction. Lastly, in the variable deceleration, the graph is usually intermittent with periodic slowing of the fetal heart rate, giving a V-shaped appearance to the decelerated areas. Here, the deceleration is variable in terms of size, shape, depth, duration, and timing in comparison to the occurrence of the uterine contraction. As you can see here, there is no pattern of synchronicity or no pattern of coincidence between the occurrence of fetal deceleration and the occurrence of the uterine contraction, and this variable deceleration mainly happens in case of cord compression. The identifying feature of variable deceleration is that there is no pattern of synchronicity or no coincidence between the occurrence of uterine contraction and the occurrence of fetal deceleration. Both of them occur at their own rate in their own frequency at a different pattern. Like here we can see one deceleration, immediately there is occurrence of uterine contraction, then immediately here another deceleration is happening after the uterine contraction. Long after that, one another uterine contraction can be seen, but the deceleration is happening long after the occurrence of the uterine contraction. So basically there is no pattern between the occurrence of the uterine contraction and the fetal deceleration, and the appearance of variable deceleration is also considered to be abnormal in the CTG graph and needs to be critically reviewed. Same like prolonged acceleration, there can be prolonged deceleration. So if there is a decrease in the FHR value for more than 15 beats per minute for a time period of more than 3 minutes but less than 10 minutes, it is considered to be a prolonged deceleration, and this indicates fetal hypoxia. But if the deceleration is extending for more than 10 minutes, then it is considered as a change in baseline FHR. Deceleration lasting for 2 to 3 minutes is classified as a non-reassuring condition, whereas if it lasts for more than 3 minutes, it is considered as an abnormal finding. In this graph, we can see that this deceleration has happened for a period of more than 3 minutes, and the decrease in the FHR value is greater than 15 beats per minute. So it is considered as a prolonged deceleration compared to the other deceleration we can see here, where the time duration is lesser than 3 minutes. So this cannot be considered as a prolonged deceleration, but this one would be considered as a prolonged deceleration. Apart from whatever patterns we have studied till now, one more pattern is there known as a sinusoidal pattern that is very rare, but it is very concerning and is associated with very high rate of fetal mortality and morbidity. And the sinusoidal pattern is mainly seen in case of severe fetal hypoxia, severe fetal anemia, and fetal and maternal hemorrhage. So this is a graph here of a sinusoidal pattern. As you can see that periodic repetitive U waves are formed in the fetal heart rate graph, and it has no correlation with the occurrence of the uterine contraction. So if this kind of pattern is seen in the CTG, it is known as the sinusoidal pattern, and this is a very concerning pattern of CTG. The characteristic feature of a sinusoidal CTG is presence of a smooth regular wave-like pattern with a frequency of around 2 to 5 cycles a minute and a baseline rate between 120 to 160 beats per minute, and no beat-to-beat variability can be seen in the CTG graph. Now we will see how to interpret the findings of a CTG. Based on the findings of the four parameters, the CTG can be the reassuring, non-reassuring, and abnormal. For reassuring CTG, the baseline FHR should range between 110 to 160 beats per minute with a variability of greater than 5 beats per minute, with no deceleration, and acceleration may or may not be present. In a non-reassuring CTG, usually the baseline FHR ranges between 100 to 109 beats per minute or between 161 to 180 beats per minute, with a reduced variability of less than 5 for 40 to 90 minutes, and typical variable deceleration can be seen over 50% of the contractions occurring over 90 minutes, or single prolonged deceleration can be seen for up to 3 minutes. In acceleration, usually accelerations are absent in case of non-reassuring CTG. Lastly, in the abnormal category of CTG, the baseline is less than 100 beats per minute or more than 180 beats per minute, or sinusoidal pattern can be seen for more than 10 minutes, and there is reduced variability of less than 5 beats per minute for more than 90 minutes, and either typical variable deceleration can be seen over 50% of the contraction, or late deceleration, or both can be seen over 30 minutes, or a single prolonged deceleration can be seen for more than 3 minutes. So in this way we can categorize the CTG as reassuring, non-reassuring, and abnormal. Based on the tracing classification, CTG can either be normal, suspicious, or pathological based on the findings of only three parameters: baseline, variability, and deceleration. Here, the acceleration is not being considered. So, in normal CTG, baseline is between 110 to 160, variability is between 5 to 25, and there is no deceleration. This suggests no fetal hypoxia or acidosis, and hence no intervention is needed in this situation. In suspicious CTG, at least one of the three parameters is found to be abnormal, but there is no pathological features present in this situation. It denotes low risk of fetal hypoxia or acidosis, and certain measures needs to be taken to correct the reversible causes leading to the situation, along with close monitoring. Lastly, in the pathological CTG, the baseline is less than 100 beats per minute with reduced or increased variability or appearance of sinusoidal pattern, and repetitive, late, or prolonged deceleration can be seen for more than 30 minutes. This suggests high risk of fetal hypoxia or acidosis, and immediate action needs to be taken to correct the reversible causes along with the adjunctive methods, and if in the last nothing is corrected, then we might need to terminate the pregnancy as well. So, what are all the actions that can be taken in a suspicious or pathological situation? First of all, mother can be given a left lateral position. This will relieve the vena cava compression. Oxygen therapy can be started. Correction of dehydration. RL can be administered at 60 drops per minute. Correction of maternal hypotension. Stoppage of oxytocin. If the mother is receiving oxytocin, we can stop that because oxytocin will further induce uterine contraction that will further lead to fetal distress and fetal deceleration. And lastly, avoid sustained pushing. If the mother is already in labor, we have to ask her to avoid bearing down effort to avoid sustained pushing. All these measures can be continued for a maximum period of 30 minutes in the intranatal period. If the situation is not corrected, the ultimate option is the termination of pregnancy. With this, we have covered almost all the aspects of cardiotocography. These are the few books you can refer for further studies. I hope this session has been informative. Once again, I would like to thank Nivedita ma'am for giving me this opportunity. Thank you. That was all for today's session.
Thank you, Komol, for such a wonderful session. Dear viewers, I hope after this session, this topic will no longer be difficult for you. If you have any queries or you want to add some information, then please mention it in the comment box. If this content is useful for you, then please put a like and share it with others. And for getting more videos like this, you can subscribe my YouTube channel in G's Corner for Nurses. Thank you for listening.